On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Using Feedback to Break the Black Hole of Event Reporting. My name is Megan Shetterly, and I will be your moderator for this program. Before we begin today's webinar, I wanted to share information about an upcoming 4-part webinar series in early 2023 that will provide information to help healthcare facilities find sources of information about hazards and safety events. Event reporting systems are a common means for facilities to learn about these things, but relying solely on this may leave gaps in knowledge and missed opportunities to improve patient safety. Today's webinar is going to address the concepts of feedback and transparency as a strategy to bridge this gap. Our patient safety liaison team is going to further expand upon this and take a deeper dive and provide examples of detection methods that may aid your organization in uncovering hidden hazards and adverse events. So please keep an eye out for registration details. They'll be coming soon. Now I'd like to introduce our speaker for the webinar today. Andy Moyer is the Clinical Informatics Specialist of Patient Safety at Penn State Health Milton S. Hershey Medical Center. He is a certified patient safety professional with over 3 decades of experience as a registered nurse and certified informatics nurse, integrating his professional nursing experiences in critical care, air medical, pre-hospital care, and an interest in system improvement and information technology. After spending nearly 20 years in corporate healthcare informatics, he returned to his roots at the Milton S. Hershey Medical Center as an informatics nurse for the newly formed Patient Safety Department. In his role, Andy assists in the hospital campus's journey to become a highly reliable organization with a safety-focused culture. So we're happy to announce Andy, and now Andy, I'm going to turn the program over to you.
Thank you, Megan. So I wanted to talk about using feedback, and we talk about this black hole, and we want to talk about closing the loop on the frontline staff's perception of reporting. So they feel this, everything's coming in with no information escaping out. A little bit about my institution. I work for the Milton S. Hershey Medical Center, founded in 1963. We are part of Penn State Health. We're a 634-bed academic medical facility attached to 130-bed children's hospital and 68 outpatient offices that report up through the medical center to the authority. You can see our hospital admissions, our outpatient clinic visits, and our emergency room visits annual numbers there on the slide. I want to really give credit to the patient safety team. I apologize to my team. This is an older picture of the team. It was a fun picture that we got together during COVID and did having a Zoom meeting, and we kind of wanted to emphasize it takes a team to reach 0 patient harms from the patient safety department. But our team reviews about 22 to 24,000 events annually. Besides the review, they investigate them, they do the reporting on them, and they're the ones who really completes the feedback that we're going to be talking about later on. It's a 13-member team. There's 7 RNs on the team. The director, the manager, and of course myself are 3 of those RNs. The other 4 are down in the trenches doing this hard work for us. There are also 2 radiology techs that work with us too. They handle all the events, and it just adds an extra level of experience and knowledge to the team. We have 2 pharmacists that work part-time, so we have them to handle our med errors, adverse drug reactions, and so on. And then the glue that holds this whole team together are 2 administrative support members. So a little bit about our program. We utilize what we call a champion model, a unit-based champion model. That simply means that we have either the clinical staff leader, clinical head nurse, nurse managers, supervisor, attending nurse, whatever you call it, are really involved in the patient safety, and they work with us on doing the investigation. They have more of the face time with the reporters. They have more of the ownership of instituting changes. So we really like that model, that we really work together on that. Objectives for today. Well, we want to identify the benefits of providing feedback and transparency of patient safety events to your staff for emergent engagement of current and future reporters. Really important there. We want to identify multiple methods of providing feedback on patient safety events back to your staff. And we want to identify how sharing insight through hindsight can improve the quality of the report information you're receiving currently. So you've heard me mention black hole. What is a black hole? NASA simply defines a black hole as a place in space where gravity pulls so much that even light cannot get out. How does that relate to event reporting? Well, you're probably familiar that frequent reasons cited by frontline staff for not reporting the events is that they just feel everything they report falls into this black hole after submission. I'm sure there's an anonymous nurse at all your facilities that have said the same thing here. My patient safety incidents go in a big black hole and nothing ever comes out of them. I never get anything back out about what I'm reporting in. So to start to address this black hole, we need to first be aware of the barriers to this. So, these barriers all add to that black hole's pull. And we also need to be cognizant of the report versus the number of events occurring. And often what we are receiving is the tip of the iceberg. I hear this number monthly at various webinars that I attend, that it's 1 out of 7 hospital-based error, accident, or adverse event is actually reported to us. And I think that number really doesn't take in the full accounting. I think that if you look at that terminology of hospital-based error, accident, or adverse event, it really doesn't pull in probably those near misses or errors or deviations that the picture on the right of the iceberg really more accurately depicts. So I think we're missing even more events out there. And I think that surface level drops every now and then, that we see more no harm events being reported. But really, the ones that rise to the surfaces are the death or harm events, or somebody really scared that they harmed somebody. Now, I mentioned that barriers to reporting add to this pull of the black hole. And there are multiple barriers. And the picture there on the left shows you a whole bunch of multiple barriers that for our staff. But I think if we use feedback, we can address a few of them. So I think feedback will help us with fear, reports not being received, fear of retribution, help the reporter know how to voice a concern, help to ease the idea over high reporting thresholds, help the reporter know how to escalate concerns or know that it's being escalated properly. And then lastly, the obvious one is lack of feedback. That's a barrier. It's a known barrier. That's part of the whole reason of the black hole conversation. So if we go through these barriers and start to look at the barriers and give a definition of them, and then on the right-hand side, we provide a countermeasure and talk about how feedback will work. So fear the report is not received. This is simply did the report make it to the correct people? Did the system eat it? The countermeasure is to provide some type of closed loop communication with kind of like a receive receipt that, yes, we did receive the event. Besides that process, there's also the benefit of direct follow-up. So if you do have a local champion, somebody receiving those events down at the local level, the ability for them to pop out of their office or while they're in the hallway to say, hey, Andy, I saw that report come in from last night. I didn't get a chance to look at it, but thanks for reporting it. Fear of retribution. Barrier is a negative, from anything from negative comments to potential loss of a job. So the countermeasures is, again, providing some immediate positive feedback, either through what we're going to describe it as a automated way, or even from that local champion. I think another part of this is having transparency of events. If you are transparent and you have a culture that you are sharing the events and talking about events, and the staff know that the focus is on the problem, not on the reporter, I think that all leads to that fear of retribution is decreased. The last thing you want to do is be counting on the rumor mill being where the event details are coming out, because we all know whisper down the alley will happen with that. And lastly, if you are not familiar with a fair and just culture, it's probably something you should become familiar with. It's kind of the middle of the road. It's not a culture of blame. It's not a culture of non-accountability. It's in the middle. It's looking and saying, did this person do risky behavior? Is it the first time they've done risky behavior? Or are there multiple times? If that's the case, well, then we need to implement something about the person. But if we look at other events, the vast majority of our errors that are occurring, we're going to come around to say there's a system problem here that's causing this to occur. And you may also find that 9 out of 10 healthcare workers might have made the same mistake of presented with all the same facts that this one person dealt with. So a fair and just culture is a good way to look at an event. It's a good way to start to explain to your staff of how you're looking at events and that they don't feel, we're using these events negatively. A barrier of how to voice a concern. That's lack of training on how to voice a concern of a patient safety event or how to escalate that concern when you're not really getting the response you need. So you can provide various trainings. We use ARC, that's ask a question, request a change, express a concern, and then go to the chain of command. There's also CUS out there, express a concern, say you're uncomfortable, and then, identify this as a safety issue. I think providing that training to all your staff, and when I say all your staff, I mean all your frontline support staff, your providers, and also your leaders. I will tell you some experience learned that if you start out and you provide this training to one group and you miss the other groups, all of a sudden you have people speaking a different language, and the receiver of that ARC isn't understanding what the person is trying to tell them. So try to roll this out simultaneously to your different areas, your different professions in the healthcare world, and that's going to help. Now, not only do you have to do training, but you also have to do some coaching, and feedback allows you to be able to give the person, the reporter, some coaching on how they could have maybe used ARC or CUS at the time of the event to express a change, to request a change. And then lastly, how to voice a concern is also about how to report to you, how to document that concern in an event report system. So providing some type of coaching or feedback on how to report those events. Another barrier is high reporting threshold. This is feeling that everything is an event and needs to be reported. And as we talk about trying to introduce that culture of near miss and non-harm reporting, staff start to feel that. And you really need to be able to provide that feedback to them to say, why is it important that near miss and non-harm events? Thank them. Tell them that it's extra time for them, but express to them that if we get these near misses and these non-harm events into the system, it's going to allow us to be proactive and fix a problem before it reaches the patient and cause potential harm. You also have the ability to do some coaching on that too. You can say, thank you very much, but this event probably didn't need to be reported via the patient safety event system. This probably could have been reported another way, and you probably would have gotten a quicker response on reporting it that way. So again, provide that coaching. You could also tell people that, I've often seen people struggle with, should I report this, shouldn't I report it? They go through the hallway, ask 5 different people, and you know what? If you have a question of should you report it, you probably should report it. And it'd probably be with less time to just report the event than you try to figure out and asking all these different people's opinions, should you report this event? Provide that feedback to them if they did a great job reporting it or if there was another way. Another barrier, escalating concern. How does it get routed to the correct people? Or how do you get through that non-response of the receiver to your concern? So we kind of go back to that non-response of the receiver, back to provide ARC and CUS training to all staff. As I mentioned, if you have a nurse trying to use ARC to a provider and the provider has no idea what's occurring when she asked a question, when she requested a change, when she said, I have a concern, they're talking a foreign language there. So try to get that training rolled out. But you can also provide feedback on how the event was handled. Combination of ways. One is you can provide feedback on using ARC or CUS. You can also provide feedback on how you escalated that. And you can also say, you know what, I really appreciate you reported this event. It should have been reported, but you probably should have done a little bit more at the time of the event occurring to escalate your concern to the appropriate people. Because now we're here 24 hours, later, looking at the event, and we probably should have, fixed this problem, 6 hours ago. And lastly, the easy one, lack of feedback. People start to question the benefit of reporting. I'm putting all these reports in, what's going on with them. It also is that idea of safety culture. So ability to provide feedback and follow up on the event is really key. I think also transparency of all your patient safety events, letting people know that on the really bad event, you're being transparent. You do not want to count on the rumor mills being how events and lessons learned get out there. You want to be in front of it, telling people what occurred, what did we learn from what occurred, and how we're going to fix the problem. And lastly, again, very similar, sharing lessons learned from previous events, from root cause analysis. Let people learn from other people's mistake. Prevent that from occurring to them. Prevent that from occurring to a patient in the future. So those are the barriers and the countermeasures and where, I feel feedback can really come into play. But I think to implement these, you really need to start thinking about building a culture, and you need to set a strong foundation to build off of. I cannot stress the importance of senior leadership commitment and active engagement of safety culture. They steer the ship, and they need to, not only talk the talk, but walk the walk. So having that commitment, that active engagement, understanding that this is going to be, they're going to need to continue this. I would recommend providing some type of high reliability organization methodology, safety culture training, team steps to all levels of your staff. Do not just focus on nurses, do not just focus on providers, but you need to have it at nurses, physicians, direct caregivers, managers, leaders. Do not miss the support staff. Do not miss your transporters. Do not miss your environmental health workers, your dietary people. I will tell you that our transporters and our dietary people are really the eyes out there seeing so much and reporting so much back into our system about safety concerns. And they're also applying all this safety concern information. Those are the people that are in the hallway and looking in a room, seeing a patient crawling out of bed. That's a fall risk. And training them and telling them how to implement and saying, you are responsible for helping keeping our patients safe is really, really important. And then lastly, again, demonstration of organizational transparency about patient safety issues. That's all part of building that culture to build up your group. And once you get that foundation built, then start adding other layers, start addressing those other barriers. Implement a patient safety champion program, or what you could also do is a safety coach program. Now, I described the champion program, a local person, down at the local level, working hand in hand with patient safety on the investigation and the solving of the problems. But a coach program is a little bit different. A coach program is, again, another staff member, not part of leadership, a peer, that we're really working with them to take those error tools, that methodology that we talked about up in building that culture, and supporting staff members. Say, hey, Andy, I saw you doing team coaching with that new nurse. That was really great. Or, hey, I saw you put that new medication on. Did you really validate and verify? That's really something you should do when you get a medication. I saw you questioning, like, was this appropriate? Go ahead and take the extra time, stop and resolve the issue that you have. Also, don't be afraid to set organizational goals around patient safety. Again, that helps to show that commitment and engagement of the organization, saying either we're increasing our number of patient safety event reporting, and once we get that going, then we're going to look at maybe a serious safety event rate or some other number that we're monitoring to say we are doing a good job. It could also be how many people are we training to be, in team steps or safety culture training, anything like that. And as I mentioned, implementing those countermeasures to known barriers. There's a whole litany of barriers out there, and feedback can address a few, but you have a whole benefit of looking at other ones. Now, I want to talk a little bit about our journey to put it in perspective of how I describe what's happening here. And I apologize. I know a lot of times patient safety departments are part of risk departments, or it's a risk department, not necessarily a patient safety department. We had back in fiscal year 16 a creation of the patient safety department out of our risk department. So you apply risk department or patient safety however you see fit if I use the term patient safety. But prior to fiscal year 16, we had a lot of progressive leadership that looked at a way and cleared the ground so that we could start this journey that we're on. So fiscal year 16 created that department. We established a reporting goal to increase the number of reporting. Late in fiscal year 16, we implemented the thank you email. We'll go over that as one of the steps of feedback. Fiscal year 17, we started talking about our high reliability organization and safety culture journey. And I say that it's a journey. I'm going to tell you very honestly, it is a marathon, not a sprint. It's going to be up hills and you're going to be struggling, huffing and puffing. Then you're going to be coming downhill thinking this is really easy. And then you hit the bottom and then you have to climb back up that hill again. Fiscal year 18, we implemented the feedback email. This is a second thing that we'll talk about a little bit later on. Fiscal year 19, after we had trained, at that point, fiscal year 18, we trained 1,000 leaders in leadership method and over 7,000 frontline or 7,000 staff members in our error prevention and safety behaviors. So at that point in fiscal year 19, we said, hey, we needed to implement the rounding that the leaderships were taught to say, get out there, start rounding with an emphasis on patient safety. That doesn't mean that your other rounding doesn't have to happen and that you can't mix the two together, but start to ask some patient safety concern questions. Try to let people know that's a priority for you. And then the safety coach program, as we described, where you pick a peer and get some peers out there to start saying, hey, are you using those error prevention safety behavior tools that you were trained on? In fiscal year 20, we updated the thank you email, changed it a little bit. And then between fiscal year 20 and 21, we continued our HRO and safety culture training throughout the organization. Now, you see, of course, we all experienced the pandemic. I would be very dishonest if I didn't say I wish that we would have had several more years of building our program before this came, because we were very new in the infancy of trying to embed these behaviors to our staff member, this culture change. And it wasn't second nature. And this really would have been great as a second nature when the pandemic hit and we were dealing with acute high census, staffing issues, supply issues, all that stuff. It really would have been nice to have that more established with our teams. But I'll tell you, we are refocused on bringing back what we had built, and we're looking at sustaining what we had grown and not losing any more ground than what we had. We'll show you a little bit of metrics of where we had grown and where we're sustaining at currently. So let's jump into the feedback that you're here to listen to about how can we implement direct event feedback, and we're using it through an event reporting system. If you're on a paper system, it'd be a little bit more difficult, but if you have a patient safety event reporting system, you should look at this. I've worked with several different facilities in Pennsylvania and across the nation, and different vendors involved. And normally the vendors can get very close to implementing something for you. So a software-based system, I rarely recommend that it's centralized, that everything is coming into one central area. Again, recommend that you can get the information that it goes to both the local level and the patient safety level or your risk department level at the same time, so you're not waiting for one to move it to the other one. That way everybody is aware of the problem and they're looking at the problem together and working together on it. You're going to need the ability to have discrete data fields. Again, I wouldn't be an informatics nurse if I didn't say we love our data. So again, looking at the discrete data fields, you also have the ability to change things and add things to that. Now, an admission discharge transfer feed for patient information is really good to tie that into your system because it makes your events work together. And again, most of the modern software systems out there have that. Another thing that we run into is sometimes they do not have employee dictionary integration, and that's kind of key here. Your ability to reach back out to the reporter is going to be tied to the fact that you have an employee dictionary and there's an email tied to that person. And then two, the system should have built-in emailing capabilities so that it's being sent directly from your patient safety event reporting system, not that you're coming back around or having to move files and things like that. Now, a little bit about the employee dictionary integration. Our system is anonymous reporting in the fact that you do not have to officially log in to our network per se to put your credentials in to start a patient safety event report. However, we have a field where we ask for the reporter's name, and we have spent a lot of time telling people between, showing them fair and just cultures, being very upfront that our focus is on fixing the problem, not on the person reporting the event. So we have great success in people selecting their name properly and saying who is reporting this event. Does that mean that it happens all the time? No. We do have some times where we get the wrong name. Is it selected by mistake? Yes, I believe that sometimes. Other times, is it selected because the person did not want to put their name on the event report? That also happens. I would say that those do not happen that often. because normally through our feedback program, they get an email saying, hey, thanks for reporting this event, and they'll let us know I didn't report an event. So those only happen a handful of times in a year. So we really think overall, most people are selecting the proper name. So we did this in 2 phases. The 2 phases came not by choice. It came about just because through iteration. So phase 1, we implemented in the latter half of fiscal year 16 was the thank you email. This was to overcome the barriers of saying, was it eaten? No, we got a receipt saying, hey, thanks. We got the event. We also focused on thanking the reporter for submitting the event. Again, knocking down that barrier, saying, hey, thanks for taking the extra time to report this. Now, we thought we could get away with offering to the reporter to contact our department to discuss the event and our eventual findings. So kind of like, hey, if you want to find out more about this event, reach back out to us. That didn't really take hold. People did not take the extra time to reach out to us and say, hey, what followed up on that event? And then this was normally sent the day after the event was submitted. This is a process. I wish our product worked that when we received the event, we could send this out automatically. That's not the way our vendor has the product. We've asked for them to consider that as a change in the future. But at least we're getting back to the reporter within 24 hours of them submitting the event. So they do have some feeling that, okay, I did do the right job and I've submitted it on and somebody's gotten it. Now, if we take a look at the layout of this thank you email, we have the ability to do the personalized salutation because we know who reported it. We embed the event date, again, having those discrete data fields. We provide the internal reference number so that, when they call us back, we can say, oh, yeah, all right, I can look up that event and give you additional information. We also then have that invitation for that direct follow-up to say, hey, if you want to know more, follow up with us. And lastly, I had all this white space here. So in 2019 or 2020, we added the SAFE bundle as a reminder to all the staff of that error prevention safety behavior training they all received that, hey, here's a reminder of that SAFE bundle. You also have it on the back of your ID badge, but here's a nice big blown up of it. And that way, when we give you some coaching later on, you'll say, oh yeah, I did see that ARC. That's right. ARC stands for ask a question, request a change, express a concern, follow chain of command, or validate and verify, stop and resolve. All that information is in that bundle right there. Now, success brings new opportunities. So as our growth of event reporting grew through a combination of an organizational goal, a high focus of patient safety from our leaders, from our organization, from all the training we were giving, the myth of the black hole grew as our numbers grew. We identified also that as we were getting all these events in, that, man, it would really be great if we could provide some coaching on using that error prevention bundle that I showed you in that thank you email. So again, man, we have all these opportunities, we see all these events, how can we give direct feedback? And another thing that as the quantity of the reports went up, the quality of the reports became very important. We no longer had the time. Initially, we were 3 nurses doing the event investigation, and you'll see our considerable jump. We really didn't have as much time to investigate a poorly written report where I made a mistake, and then we had to go track the person down and spend a lot of time back and forth on saying, well, what mistake did you make? And find out that they just transposed the temperature with the weight, something like that. So really improving the quality of the reports given to us. And lastly, as being part of a College of Medicine, we were asked to expand our focus to increase the reporting by the residents, fellows, and our medical students. And with that, we were given the opportunity to go and talk to these people early in their training, talk about patient safety, the importance of it, try to get them on board early in their career to say, wow, this is really important, and wow, this is how you play a part in fixing that. So we jumped on that right away. So part of that assessing, improving the quality of the report, this again originally came from our College of Medicine saying, hey, when you're increasing the reporting, can you start to assess the quality of our residents reporting? And at that point, we kind of paused and said, we looked at a tool and looked at this from the Association of American Medical Colleges and said, wow, this is really a simple tool to use. And as we're looking to how do we operationalize that in our system, we kind of identified that all reporters could really benefit from constructive advice or coaching and voicing their concern to us. Make them an improved writer. Tell them that they need to write the report for another reader, not for themselves. We're not experts, and healthcare is very diversified. Yes, we're nurses, yes, we're radiology techs, but there's processes and procedures and things that we're not familiar with in your particular area. So you might report something, we have no idea what that means. So kind of change the way you're writing this. And then lastly, we saw the ability to apply our organizational values. And our organizational values are respect, integrity, teamwork, and excellence. And you're going to see how those really come into apply. So when we could tie that back to our organizational values, as far as how they're writing the report, it really worked out nice. So the report assessment tool, the left-hand side of this image shows the one from the Integrating Quality of the American Association of Medical Colleges. So this was what we originally looked at, and you can see type of event. All right, we had that information. We know that's what we're already putting in the type of the event. It could be the PACERS type of the event. And then we get down to the quality report, and they looked at timeliness. That wasn't a concern of us. We knew our reports were coming in. The vast majority were being reported within that 24-hour time period, so not a problem there. Then we looked at clarity, objectivity, and language and professionalism. And we really liked that and said, okay, this is how we can tie in that respect, integrity, teamwork, excellence. You see how that respect and teamwork all comes into professionalism and, integrity on clarity and objectivity, things like that. Lastly, they had a free-form text area for you to write in the outcome of the event. So if you look to the right of this image, you'll see a table, and in that table, you see that we took those and added clarity, objectivity, and professionalism, but then we added accuracy. That was something we wanted to look at improving the accuracy of the report information we were getting. So if you look at the top four there, you're going to see choices there that are only two. The one choice is a very positive choice, and the other choice is a constructive advice choice, giving the person a little bit of pointers to say, yeah, you maybe could have done a little bit better here, right? Outcome is giving that person a little bit more in the disposition of the event. So the choices that we have that we can put in there is initiating a apparent cause or root cause analysis, putting out a safety alert, a referral to leadership or somewhere else, submitted to our MedSun MedWatch for FDA reporting. And then lastly, the one that the most of them go to is report retained for tracking and trending. And that's something that you got to remember, and you got to be able to continue to share back out to the people so that tracking and trending is not a sigh, yeah, that's where they all go. You also have to share that data to people and understand that you are looking at it and you're trying to pull out trends and be proactively about trends that you're seeing. So we'll talk about that a little bit later on too. So that was our report assessment tool. We said, all right, this sounds good. Let's really start to implement and operationalize it. We kind of did a pause then and said, well, before we start critiquing people's reports, we maybe better define the expectation of what we want from them, of what we expect of that reporting to come in. And we created this guideline, and we shared and educated on this about 60 days before we rolled out the first assessments. We also provide a reference back to this guideline, actually in the feedback email, and you'll see that here soon, where they can go back and say, what are you judging me on? And then there's an opportunity for them to click a link, come back and look at this paper, right? Now, while we're doing this, we know that we're going to have to be prepared for individuals not willing to accept the constructive advice we're going to give them, all right? And you're going to deal with two types. You're going to deal with first a type that's going to really vocalize their dislike on your insight from hindsight and say, I think you're totally wrong. I don't know why you did that. And you're also going to have that silent group too that are going to be kind of turned off by it. So you got to be prepared to say, yes, we're going to have some people like that and do it. I'm going to tell you that you need to embrace that opportunity for those that vocalize that dislike and have a one-on-one. I was very fortunate with my previous and my current director that they take that opportunity to go have that cup of coffee chat with that person. And they, go to the cafeteria, go to an office and meet, sit at Starbucks and they, first of all, listen to the person hear about what their gripe was about the feedback they got. And then they were given the opportunity to explain what we're trying to do by it and why it was done that way. And, most times we reach a happy medium and the person, understands what we were trying to achieve with that. And that also offers you the opportunity to hear and talk to that person about other issues going on of a patient safety nature, things that you probably wouldn't have had the opportunity to discover if you didn't have that one-on-one. So I would just say, be prepared that people are not going to be happy with that. Embrace that opportunity. Figure out a little bit more about how you can address that silent group. If you hear grumblings going on, try to get in front of that sooner than later. So phase 2 of our feedback process, and this was the actual feedback email. So this provides the outcome post-investigation. Again, it shows transparency. We're trying to give you more information about events. They're coming in. We're sharing that information out to you. We're doing that, providing insight through hindsight on the quality of the report or how you voiced your concern and documenting it. So that was one thing. We personalized the response to demonstrate a review. In that personalization, we provide the opportunity for us to do coaching, how you could have maybe written this differently, how you could have used error prevention safety behavior tools, how to address those thresholds. So again, tackling those barriers. And then this is sent the day after designation. So this can be a day to several days after the event was received. So it's not immediate, and it wouldn't be. You want us to investigate the event, get all the information, make a designation, and now share that back to you. If we take a look at this email's layout, very similar to the thank you email, personalized salutation. We again want to share that internal reference number so that we can have a conversation about what event are you talking about. We look at the event date, the event type. We put in the disposition of the event. This is very similar to the PACERS event type. Oh, I'm sorry, the event type is similar to the PACERS event type. Disposition of the event is that list of, was this apparent cause, root cause analysis? Did this lead to tracking and trending? Was this referred to leadership? We provide that link to that reporting expectation. So again, if the person is saying, what were you judging me against? How did you assess my report? There's that link to go back out there and say, okay, all right, I see what they were looking for. The free text comment area, this is where you can personalize it. And over the last year, our team has really started to use this more. This is really great where you can add a little bit more and pull out that this isn't just a form letter. This is actually somebody taking the time to mark all this information and give you feedback. This is the place where you can also provide that coaching to the person to say, hey, this would have been a great opportunity to do ARC, or wow, really great on using validate and verify. Hey, threshold wise, this was a great catch that you reported to us. Thanks for doing it. It's really important. So personalize that, make that area available to them. And then lastly, we always invite the people for direct follow-up. So if that direct follow-up is to talk a little bit more about the feedback, maybe they wanted to know, well, what really happened from the root cause analysis? That's one thing. Or maybe it's to, again, express their dislike with how you assess their reporting. So automation of these. So both emails are processed daily by our administrative support members. So they really come in and do this. The process is similar to running a queued report. And what I mean by that is when they open up our reporting system or into our event system, these reports, these letters, these feedback letters and feedback thank yous are already processed, already stamped with the people's names, everything's ready to go, and they simply select export via email. So it's really not that much of work. The total time to access and send a total of 130 to 150 individual emails is about 2 to 3 minutes. And that's 130, 150, that's between the thank you and the feedback email combined. So anywhere in between that number. So we normally are doing about 90 events a day are coming in, and we're doing about 60 events being processed out that we closing the investigation on. So somewhere in those numbers, higher or lower. So if you think about that, if you say, wow, less than 5 minutes of somebody's time, we were able to reach out to 130, 150 people and provide some form of trying to knock down a barrier, some form of direct feedback, some form of coaching, some form of personalized thank you for them reporting an event, that's probably a really good time. Even if it was 10, 15 minutes, that time of 130 to 150 contacts, really worthwhile. So I'm going to jump into our metrics and talk about monitoring effects or efforts. I think, again, as an informatics nurse, we look at metrics. We always are looking to say, how are we doing and measuring ourselves? So this slide first talks about our growth of patient safety event reporting. I added fiscal year 12 through 14 in there, but fiscal year 15 is what we're going to use as our baseline going forward. So we sustained growth from the time of the initial organizational goal. If you remember, that was fiscal year 16 when we said, okay, we're going to raise our event reporting. We did have a significant jump at the time of the feedback email, but I want to be clear, there are other processes were occurring during this whole time, that was showing that patient safety was an organizational priority. So can we say it was all feedback? No. Do we feel feedback was part of it? Yes. I think too, during this whole time, we increased our transparency about all events. So again, we show to our people that the information you're giving is important. We're sharing out information to you via transparency of those events or feedback. If you look here too, we jumped in from fiscal year 15, our baseline, to 16, the organizational goal, by 70%. If you look up at fiscal year 19, after we had done all that training, all that feedback email, everything like that, we were up 242% from our baseline. So a very significant jump over that time. But let me be very transparent too in saying that, we did not fare as well with COVID. When COVID came and the pandemic came, initially fiscal year 20, our initial drop was just due to the reduced patient census, due to those several weeks where, non-emergent events were not being seen in our operating rooms or admissions or outpatient clinic visits. And it was really neat. We were monitoring our patient safety event rate with our patient safety events with our census numbers. And we had a very nice correlated parallel line that we've been monitoring for that whole time period through fiscal year 17 and 19. And fiscal year 20, when the initial pandemic hit, our numbers dropped and it mimicked exactly for patient census number. The decline looked exactly the same. And when we came out of that initial pandemic, where we started bringing patients back into our outpatient clinics and started doing non-emergent hospitalizations and surgeries, again, our rise mimicked that too. But we never got back to that same parallel line of patient safety event to census rate. And actually, our census rate has grown post-pandemic, but our patient safety event rate continued to drop. So we are facing a 25% drop in event reporting from pre-pandemic. Now, we can talk about litany of reasons, from competing priorities, staff being tired, staffing levels, patient acuity, so on and so on. But we see this as a great opportunity to come back, refocus, and put the patient safety of the organization as a priority. And that's what we're working on. So even though our numbers did not drop below when we started this journey, our goal is to sustain and refocus and get back up there. You can also look at your employee survey data. So either your culture of safety survey data, employee survey data, however you do that. We've had a question in our culture of safety and now our employee survey data about we are actively doing things to improve patient safety. And you can see that from 2018 to 2022, staff have appreciated that, yes, things are occurring. The goal is, I would love to hit that 90% mark here in our next survey and continue to show and that staff feel that we're doing things to improve patient safety. You can also add another question. And since we put in feedback, we added this question in 2019 and 2022. We are given feedback about changes put into place based on patient safety event reports. So tying it directly to the feedback of event report. I presented this kind of how the culture of safety survey data would be with unfavorable, neutral, and favorable. You can see the blue is 2019, the orange is 2022. You can see how favorable jumped up tremendously there in 2022. So you might want to consider a form of this question to establish a baseline and measure a change if you're looking to try to implement a feedback program. Be a good way to measure, are you hitting all the points? Now, I like to drill down by profession in this data. So I take that, are you getting feedback? And I look at by the profession of the reporters. So I can find out that 70% of the favorable responses were nurses and 59% were providers. That's a great mix. I'm very happy with that. We know, first of all, nurses are the largest group to report events in our system, so they have the most exposure and awareness. If we look at unfavorable response, 10% of nurses, 18% of providers. I wish I had a follow-up question, and it's something that you might want to consider. I remember in the old culture of safety survey, it used to ask how many patient safety events have you entered in the last 12 months. I think it would be great to have you entered even one in the last 12 months to see how that qualifies and say, if I look at those 10% of nurses, well, none of them reported an event, or 90% of them didn't report an event. That might be part of the reason. But you also need to look to say, are they missing the other methods that we're giving feedback on patient safety events? So look at opportunities to increase the exposure and awareness to providers or that unfavorable group that you see of lessons learned and changes. See how you can raise that awareness. You can also look at evaluate what departments have the highest and lowest responses for opportunities. So take a look at that. Lastly, in metrics wise, we looked at that quality report of the narrative. So this graph here talks about the frequency of constructive advice. So this is when we had to give somebody a little bit of nudge, urging to say they could have maybe improved the documentation. So 2018 is the dark blue, 2022 is the light blue. So the idea here is to get to a smaller number. So you see we were very successful in improving clarity, improving professionalism, and improving objectivity. Professionalism went up a little bit in 2022 versus 2021, but not that much that I'm worried about. So the combination of expectation setting, the feedback, and coaching helped to improve that in the reporting, the narrative section of the reports that we were receiving. The next part is the accuracy section, and this is really focused on the data selection. So selecting correct location, events, type, medication choices. Again, we look here and you say, well, wow, we are above what we started out with in 2021 and 2022. Now, again, do we go back and we look and say, staff not focused when they're entering these events? Is there something going on for systems? So we have to look at this a little bit more to see how we can improve and help our staff be more accurate with the reporting that they get or what they give us. So this is something that is a work, but again, we're happy to get that information reported to us. So we talked about our ways of feedback and how we're using our event reporting system to do automated feedback via emails to our staff. But, there's other ways you can provide feedback. And I think the biggest one is transparency. We implemented this picture here on the left is on the main page of our Infonet. This is days since last serious safety event, and you see the calendar showing 19. This is very similar to if you are at a factory or job site, days since last job injury or work injury. Very similar concept. So we advertise that to the people. Let me just clarify, we use the Press-Ganey safety event classification system. So a serious safety event is an event that is called permanent or temporary harm or death that was preventable. So it's different than a patient safety authorities or PACER's serious event. Every serious safety event will be a serious event in PACERS. Not every PACER serious event will be a serious safety event. So that preventability is that key part there. And that's where we see the most opportunity. When we have something that's preventable, that's where we have the opportunity to fix the problem. Now, not only do we show that count, but if you click on that See Details, the image to the right will open up. And I apologize for the blurring, but there was just no way I could provide the information, outside of our facility. But to all our staff members, whoever has access to the Infonet can read a de-identified story of what that last serious safety event. Now, de-identified is not just, yes, of course, we want to add the patient's name or the staff's name, but it's also trying to de-identify the location, de-identify the professions involved, things like that, if at all possible. So we are transparent about what harm we caused, what was the outcome of that harm to the patient. The neat part about that is the second paragraph is a challenge question back to the employee reading this. And we write the challenge question to be to work for anybody, not just a direct caregiver, but also for our accountant, our accountants, our administrative assistants, the transporter, anybody like that. So we talk to them about, say, have you ever had a situation where this occurred and you didn't do closed loop communication with someone and you ended up not doing what the person wanted you to do? Have you used closed loop communication? And then we go over that error prevention safety behavior tool again as a means to coach to say, this is what you can do to help prevent errors. We also share on the same page your lessons learned from a root cause analysis, again, providing the opportunity for people to see what's going on with all that information that's coming into the system. So providing this, having transparency of your safety events, not letting things be swept under the carpet and not talked about, that probably is the wrong thing to do. We're all probably beyond that today, but increase that transparency and show that. Local feedback role, the ability for the local person. Now we use that champion model and we really talk to our champions that they can follow up directly with the reporter. They have that ability to give that direct feedback to the reporter. That could be, hey, great job on that great catch. Maybe you have an awards program. Talk about significant trends. Say, hey, Andy, thanks a lot for reporting that. That's the second one I received. If you hear of anybody else that's having that same problem, get them to report it to it so that we can really start to monitor that. Identify that lessons learned. Maybe it's lessons learned within that particular unit or clinical area, or maybe it's lessons learned that are coming down from the patient safety risk department that, here's what's going on throughout the hospital on lessons learned. And lastly, actions being taken. Probably the people closest to what's occurring to fix problems going on at the local unit is this champion or the leadership at that local role. They can express to the team to say, look, we've had several events reported on this IT issue. IT has the ticket. They told us it'll be about 3 weeks before they can fix it. I'll keep updating you as I hear more back. Oftentimes that's missed. So reporters are reporting things and they're not hearing that there's work actually being done about it. Now we use a shift huddle concept. So every shift, the new shift comes and they huddle around these huddle boards. That's what this image is. They discuss key events. There's columns in each things to discuss, but they discuss key patient safety events. They can identify significant events on the huddle board. So maybe it occurred over the weekend. I'm coming in Wednesday. There's kind of a de-identified story to prompt you to say, oh, what happened over the weekend? And then lastly, post stats on the huddle board. So take those analyze tracking and trending thing and show people you're looking at that data. If it's not coming from you locally, maybe your patient safety risk department can generate information out to you to show you either hospital-wide or at the local level what's going on, but try to have some ownership at that local level. So when I look at this for next steps for us at Hershey Medical Center, we're really considering providing a link to a survey tool so that the people, when they receive their feedback, can come back, do that survey tool, give us feedback, again, allow them to come back to us, offer us feedback. Maybe we'll get over that silent majority or silent minority that are disliking what we have to say to them. Also ask them questions, ability to have more of a two-way conversation. Lastly, refocusing on our high reliability and safety culture behaviors post-pandemic, just due to the ever-changing staffing level and census. We're going to continue to analyze our culture of safety survey data by job titles and work area to identify trends. And we're going to continue to review that feedback data by job title and work areas to say who's doing a really good job and how can we maybe find out who needs some support, and maybe taking that secret sauce that one department are doing and move that over to Department B and say, hey, maybe this is something you can try. Start to share those lessons learned on success. So if you want to hear more, American Society for Healthcare Risk Management has some really great podcasts on various topics out there. Take a listen to them. I was fortunate to do one here earlier in the year. I think it presents the same topic in a different tone, and you might get more out of it. It might be something you want to share if you want to introduce the idea of maybe we should be doing feedback at our facility. It might be a great way to introduce them to it. It's a nice podcast, maybe when you're driving into work or driving home from work. I really love to hear your feedback to me. You can email me at amoyer1@pennstatehealth.psu.edu. I'd love to talk to you about anything that you have, how to implement a feedback program, any successes or barriers that we have established here at Hershey Medical Center. But please feel free to reach out to me. There it is. At this point, I'm going to turn it back over to Megan.
Thanks, Andy. That was a great presentation. That does conclude our slide presentation portion of the program. We now would like to begin our question and answer periods. Why do you send 2 emails to the reporters for each event?
So the initial email was the thank you and the read receipt email that, yes, we got it, the system didn't need it. And then when we implemented the feedback, we went back and started pulling people to say, well, can we remove the first email? And they were like, no, we really like that confirmation that it was received. So that's why we send out 2 emails. Do you need to do it? No, but I think the ability of knocking down that barrier and giving them that initial confirmation, we got it, and we're working on it, and thanking them probably works out.
Thank you.
Does the speaker use the Midas system as their event reporting system?
Yes, we do.
Any recommendations for first steps on changing leadership culture and/or mentality to refocus on high reliability principles? She says, totally agree that executive support increases success of system-wide culture.
Yeah, I think, that is the hard thing to do, and really engaging your leadership, your senior leadership. And you really want to get in front of it. Having had experienced a really negative, high-profile event, you don't want to have that be the trigger to set this off. You want to have something in place doing it. We had this in place when our negative, high-profile event occurred, but we weren't fully implemented in it. So at least we weren't playing catch up. So if you can get in front of your leadership, and start talking about this, there's a lot of white papers out there that you can find on how to speak to your leadership and engaging them. And I might be able to share some for you if you want to email me and do that. But that is the key. Your leadership have to walk the walk with you.
Thanks for that, Andy. Well, I think we're really up against time here. I just want to thank you again, Andy, for that really fabulous presentation today. Really a lot of great information. And just a reminder to everybody to stay tuned for our Outside the Box webinar series, where we're going to help people to identify potential safety events within your organization, and registration details will be coming. So this will conclude our presentation for today. I just want to thank everyone for joining us today. If you experienced any issues accessing the evaluation and/or the certificate of continuing education, please feel free to direct any inquiries to Shelley Meixel, and her email is shmixell@pa.gov. This concludes our webinar. Thank you.